Antithrombotic therapy after acute coronary syndrome or PCE in artery fibrillation. Definition: normally blood flow through our arteries and veins. Should it infinite but is clogged or thrombosis blobs, the show flow of blood. The Rosalind-Killen thrombosis can be serious and even cause death. We now are aware of drugs that can be used to prevent and treat thrombosis and treat and more on the web, but it was not always the case.
Your heart is a muscle that pumps blood around your body. It's made up of 4 chambers, 2 at the top called the atria, and 2 at the bottom called the ventricles. Your sinus node sends out electrical impulses. Atrial fibrillation, or AF for short, is when other areas of the atria send out electrical impulses too. These irregular impulses cause the atria to twitch. When this happens, blood isn't pumped out effectively, which could cause a blood clot to form. If this clot travels to your brain, it can lead to a stroke. When your heart isn't pumping blood properly, it can lead to symptoms such as tiredness, dizziness, or feeling faint, shortness of breath, or palpitations. How AF affects you will determine the treatment you need. Some people with AF, like Harry, only have mild symptoms, or may not experience any symptoms at all. Harry noticed something might not be right when he felt his pulse was irregular, and sometimes fast. Harry was at higher risk of AF because of his age and high blood pressure. Those with a heart valve problem are also at a high risk. It's important that Harry avoids further strain on his heart by getting treatment for his AF to reduce his risk of stroke or heart failure. The best course of treatment for Harry was anticoagulant medicine, called warfarin, to reduce his risk of having a stroke, followed by a cardioversion, to try and restore his normal heart rhythm. However, some people may need other treatment, such as ablation or other suitable medication. Thanks to his treatment, Harry's AF is manageable, and he can return to work and exercise when he feels ready. For more information on living with atrial fibrillation, visit bhf.org.uk/AFib. BHF. Beat heartbreak forever.
Application in medicine. A prophylaxis 1 and 6% wide atrial fibrillation will undergo precocious coronary intervention, PCE, or have acute coronary syndrome anticoagulate in should patient in coagulation.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual
Pros and cons. Pros: in paintings ordering completing multis or heat crease PCE, or in those presenting white heat crease acute coronary syndrome are experienced should probably not be rolling on Monday for at least several weeks or longer, depending on bleeding risk. Const. The consenting of the dress to heart morning thrombosis event in the blowing growth that it take aspirin grouped strongly suggestions that here may very well have been a significantly different and more patient had been enrolled in August trial. Used application in Ecuador. Cleaning decision making should continue and have this whole balanced as met of three competing reasons: cardiology, stroking, coronary asphyxia, eventing, and blinking. According to Take Ecuador, cardiology imaging of offices medicine no anticoagulant should be proven while patients with a score of C. Conclusion. Although Gillen comments well now have to grapple why incorporating the result of the August trial into expectancy recommendation is this clear that on side first add policy is only to apply in these patients.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin, obviously, before PCI in the hospital, but then at discharge, stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in the Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after, or at the time of discharge, that you'd send people home on the dual therapy and allow risk stratification if you had a high thrombotic risk, a left main stent or something. I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.